Thank you to both Elijah and Sanjay for, yeah, I know I'm a little taller than the average mutant. Thank you to both Sanjay and Elijah for the wonderful invite here. It's great to be here. Yesterday we had a nice day at the AICC as well. Want to talk this afternoon a little bit about early repolarization. Fundamentally, I guess I have to answer this question: is this a disease? I'm going to take a little less of a mechanistic approach to this, at least at the beginning, before we try to answer that question. Talk a bit about the clinical observations, since I am a clinician and not a basic scientist. There we go. Okay, so I showed this ECG yesterday as well, or one very similar to it. This is a pre-op. This young man was a weekend warrior athlete who had a bad knee. Went for his ACL repair with an endoscopic procedure, and this was his pre-op ECG performed because, as you can see, he has pretty marked sinus bradycardia. And this then resulted in an urgent cardiology consultation because this asymptomatic male was, of course, had a pulse of 40. And the question was, is this normal? So we posed that question, is this normal? And I'd like to perhaps conduct a poll and ask you to raise your hand if you think this is normal. And after that, your alternative will be to raise your hand if you think this is abnormal. Raise your hand if you think this is normal. And if you think this is abnormal. Okay, so that's at least soft equipoise. Standing here, about 30 to 40% of people said it was abnormal. 50% said normal, and 10% are abstainers. So what about this? Is this normal? So I don't think we need to conduct a poll in this situation to say this is abnormal, but this is a patient whose cause of these nasty-looking series of bursts of abnormal rhythms was attributed to early repolarization, since there were no other mechanisms detected. And so this poor guy, in fact, I got an email this afternoon saying that we had managed to renew his quinidine prescription with difficulty. It does not think that that preceding ECG is normal. So a little primer on early repolarization, and then talk a little bit about some of the clinical observations. So first of all is how we measure it. There's two elements to early repolarization on the ECG. First is the notch in the QRS. It almost looks like a reverse delta wave. And the second is the ST elevation. And varying degrees of this are present in any individual. It's typically seen in the inferior and lateral leads, and it doesn't count if it's seen in the anterior precordial leads. And we measure the amplitude of these based on the isoelectric line as illustrated here. The Heart Rhythm Society, ERA, and APHRS have come up with a definition, and Arthur will remember I was part of this discussion process, what nomenclature we use. We took a chapter out of the original discussion around Brugada by using the terminology of pattern and syndrome. And one of the reasons for this, which I'll get to in a little detail, is you can find early repolarization if you look hard in a lot of people. In some populations, as many as 40% of athletic young males. And so as a result, we did not want to label patients as having early repolarization syndrome if they were like our pre-op arthroscopy patient. So we went back to what people may recall was the nomenclature of Brugada by calling it an early repolarization pattern. If you have 1 or more millimeter of ST elevation in 2 or more contiguous leads, and we used syndrome to define those people who had the pattern and symptoms attributed to that ECG abnormality. And this breaks, if you like, breaks league with the Brugada nomenclature, which got rid of the term pattern. So this is indeed a conundrum, and this will have to be our little secret here this afternoon. So we can see this easily in 5 to 10% of healthy people, particularly in young males, athletes even more so. In those situations where we believe rhythms are attributed to this abnormality, events typically occur at rest or during sleep. I think I'm going to gloss over something that could be aptly discussed, and that is that the majority of patients that you see do not have a clear evidence of a genetic basis. They don't have a family history of sudden death. You can screen their relatives, and there doesn't appear to be a lot going on. In all of our enterprises of screening sudden death families and so on, we generally do not find an autosomal dominant familial sudden death story to go with patients where we attribute their rhythms to early repolarization. I'll talk a little bit about the overlap syndromes, but I consider early repolarization to be like the sequel to Brugada. So if you think of Brugada, we see it in every, 1 out of every 1 to 5,000 people. It occasionally causes life-threatening events. It drives many of us crazy because we see a lot of this, and you've felt are grappling with risk stratifying these patients. Early repolarization is like the sequel. It's bigger, it's louder, it's got a lot more action, but it leaves us feeling hollow. And the reason for that is it's much more common. It's much less likely to cause any trouble than something like Brugada, which actually at least is a disease, regardless of whether you fall on the repol or dipole hypothesis. And so, for example, 40% of people have syncope once in their life. 10% of people have early repolarization at least once in their life. Do not tell primary care physicians that those two things exist. We will spend the rest of our lives seeing vasovagal syncope with early repolarization. So this must be our little secret. Okay, so what is the evidence? So this is actually the landmark paper from 2008 led by the French group from Bordeaux. But this is not the first evidence. The first reference to this is in 1947. And about every 10 years, some lonely prophet in the wilderness is saying in some journal somewhere that early repolarization is not benign. And there are occasionally patients where it appears to be mechanistically related. And this was a terrific paper because it brought to light the question, send us your cases of unexplained cardiac arrest or idiopathic ventricular fibrillation, and we're going to look at ECG predictors. And this is where the observation was made that about a third of idiopathic VF patients have evidence of early repolarization. And when they're compared to controls, their control rates are about 5%. So it's heavily overrepresented in patients who have idiopathic VF. And the other thing is that the electrocardiographic parameters seem to be more accentuated in the context of when patients are unstable. So that was, if you like, part of the landmark evidence that we should call this to attention in that small number of people that we have with idiopathic VF. So the next paper, there we go. The next paper is from a terrific large-scale epidemiology study from Finland. Professor Hikuri and his group of investigators have published a series of papers. I'll show you a few excerpts from that. So I draw your attention to a couple things. So first is this is 11,000 people. So this is not a trivial cohort. This is a supposedly unselected cohort. And the other is look at the x-axis. Average follow-up here, we're talking about 40 years of follow-up. So this is an impressive natural history study in this population. And so what you see here is, in blue you see the individuals who have no J-point elevation, and in red you see the people who have 2 or more millimeters of J-point elevation. And so when you had 1 millivolt of J-point elevation, your hazard ratio for cardiac death was a little bit elevated, but not terribly high. When you had 2, it was up by 3-fold. The number of patients it involves is a very small number, so this now becomes a palatable number, a little bit like our Brugada population. But if you look at when that risk happens many years later. And I'll tell you that it turns out to be much more associated with predicting things like coronary disease and heart failure, not predicting idiopathic ventricular fibrillation. So second observation came actually from a registry that we run in Canada looking at idiopathic VF and unexplained cardiac arrest. And we looked at that population within our IVF population that had evidence of early repolarization. And one of the observations that was made is that the pattern can be fluctuant, just like it is in Brugada. And I'm not trying to say that early repol and Brugada are the same, but there are some alignments in thinking. And so here's an example where you see somebody who, day 2 after their cardiac arrest, has clear evidence of both notching and ST elevation, but day 1 and day 4 does not. So having moved to a different city in Canada 2.5 years ago, I'm now having a bunch of idiopathic VF and cardiac arrest and inherited cardiomyopathy patients repatriate into my clinic to say, we have a new guy with fresh eyes, review the case. And what they may have done when the early repolarization data came out was looked at an ECG and said it wasn't there. But what they didn't do is they didn't look at an archive of ECGs, particularly around the time of instability when they had their arrest. And that's often where there's gold and you see evidence of early repolarization. So the next one has to do with 2 patterns that can be helpful to individuals, and that is the nature of the ST segment slope. And so you see here, this is the ECG of an athlete who has a relatively upsloping or steep ST segment slope. that is typically seen in young, healthy males and is often benign. This is in contrast to where you have ST segment elevation, where you see here you get notching, and the ST segment is relatively flat and can even be downsloping. And that ST elevation slope has been correlated with actual mortality from early repolarization. So in the end, we have, although it's a little oversimplified, we have something that says if you have 2 or more millimeters of ST elevation, if you have horizontal ST segment elevation, then in fact, this is the bad pattern. This is the pattern that's more likely to be associated with risk for ventricular arrhythmias. And this upsloping steep pattern here is what you see typically in young, healthy, especially males and athletes. And that's borne out in the population study by that large Finnish group again, that again looked at the 11,000 patients, and then the curves here, this is the reference population, this is the upsloping ST elevation, and this is the horizontal or downsloping. So again, there seems to be an association, but again, you notice from the natural history perspective, right? We started off with 11,000 patients. It takes 20, 30 years for those curves to start to come apart. So this is not an urgent reason to get excited about risk for ventricular fibrillation. This is the one study that I think has some compelling evidence for a genetic basis in what is pretty much the exception in early repolarization. And this is 3 large French studies that essentially had familial autosomal dominant unexplained sudden death. And the connecting factor in these individuals was evidence of early repolarization, either on ECGs that were performed before their mortality or in individuals who were obligate carriers. And in fact, they used Valsalva maneuver to try to provoke the pattern in obligate carriers who did not have the pattern with varying degrees of success. And I'd welcome the other individuals who will be involved in the panel in commenting, because we have not been successful in provoking this in our population. So a brief word just to say where some of the mechanistic thinking comes around in this, how we're going to get to this, and that is that the treatment of the arrhythmias that arise from early repolarization has a lot of alignment with idiopathic ventricular fibrillation, Brugada syndrome, and short QT syndrome. So there's, if you like, a bucket of things that all come to a commonality of generally responding to immediate treatment with, in North America we call it isoproterenol, you call it isoprenolone, and quinidine. And quinidine, if people read the literature, is a drug that's very difficult to gain access to, with limited production in a generic fashion, and so each of you in your own environment will go through your own struggles. We discussed this yesterday about the struggles we go through to try to access quinidine. Many of us who have very few children have given our first few to the Health Canada or regulatory boards to get some quinidine for our patients who are dying. Okay, so what do we tell patients? So in the patients who have had a cardiac arrest, you say, welcome back. We don't know why you're here or why this happened. We'll get back to you about that, but we have to implant an ICD. We don't have another way around this. In asymptomatic patients, this is elegantly summarized in a nice little review by Sammy Viskin, and email me, which I'll give you my address at the end of this, and I'm happy to pass that along. But before the age of 45, the risk of dying suddenly is 3 per 100,000 per annum. If you have any evidence of early repolarization on your ECG, that risk goes up a little bit. That's what the Tikkanen, that's what the Finnish population study would suggest. If you have horizontal or downsloping ST elevation, your risk goes up a little bit further to 30 out of 100,000. So that's 3 per 10,000. There is nothing that we can do, probably including a drive to the hospital to see the doctor, that is lower risk than that. So despite the fact that there is some tiny attributed risk, it's not wise to intervene. There's no role for an ICD in a patient who is asymptomatic. Okay? And there is a tiny little asterisk at the bottom of this that if there's familial sudden death and you have no other explanation for this and there's strong grounds to believe that there could be familial early repolarization, that person should be in a research study and might be eligible for consideration of an ICD. So that sort of language. So I think of much greater relevance, rather than these extraordinarily rare situations where early repolarization is a cause for recurrent ventricular fibrillation, is that in fact early repolarization is, if you like, part of the complexion of contribution to risk to sudden death. So this is part of our channel mosaic, if you like, our repo mosaic that puts us at greater or lesser risk. And Connie had a very nice, elegant presentation about the genetic basis of that this morning Even it was impressive to me because it was done without illustration, and I still understood. So this is an example here. So let's start with something a little bit akin to what we've been talking about. So this is Brugada. Elijah will like this. So this is the risk of patients who have Brugada with concomitant no early repolarization, intermittent early repolarization, and persistent early repolarization. And although this is a small preliminary study, and the risk here is for recurrent ventricular arrhythmias, what it suggests is the two together are a bad combination. So it may be a measure of a more severe form of Brugada, if you like, but nonetheless it is an association that's difficult to deny. A second paper then also looked at when Brugada patients storm, when they have flurries of shocks, are they more likely to show evidence of early repolarization? And the answer is yes. This is a paper that was just published in September. So again, if they're in the Brugada patient where you've been focusing on the ST segment elevation, if you look carefully, what you'll see there is that QRS widening with notching and some degree of ST elevation. So again, early repolarization appears to compound other conditions much more often than it's actually causing a disease all by itself. We looked at this in long QT syndrome, and when I saw the paper about Brugada, it was interesting because I thought about this and I immediately pulled those patients that I looked after in my clinic who were inherited ion channel patients who had had shocks in the last couple of years. And I looked at their resting ECGs, and what do you know? Most of them had some degree of inferior lateral ST elevation. And I thought maybe there's something to that. And so we then looked at our long QT patients because that was our biggest population. And what we found that was interesting is that there seemed to be a strong association between evidence of concomitant early repolarization and being more likely to have experienced symptoms. Not much happens in long QT after you identify them because our treatments are so good. So we were looking retrospectively, so this is sort of provocative or hypothesis generating. But interesting, in that relatively modest population of 113 patients, in fact, early repolarization, 2 or more millimeters, was more predictive of symptoms than the QT duration. So, if you go back and you have a look and so on, I think, again, it's compounding the severity of early repolarization, or of long QT syndrome in this situation. So let's move on to another area. So let's get away from the ion channels, which we, I think, are all a little bit more comfortable and familiar with, and let's look at a more common situation like myocardial infarction. So this is a Japanese group, and this is their second paper on the topic. Their first paper was to say that when you present with a STEMI, with an acute myocardial infarction, you are more likely to develop a cardiac arrest and have a bad outcome while hospitalized for that if you have early repolarization on your presenting ECG. We might have historically called this reciprocal changes when you have ST segment elevation in one zone, if you like, and changes in another zone. But when you think about it, reciprocal changes don't necessarily follow vascular territory, so there is some sense to that. This is the follow-up that says that even after all that, when you take that into account, and then you discharge over 1,000 patients with their infarcts and look at their follow-up after 2.5 years. In fact, early repolarization of the strength, if you like, of things like ejection fraction or heart failure class can predict adverse outcomes. And so I've highlighted it here at the bottom because the univariate predictors of bad outcomes, okay, so this is VT or sudden death, Killip class, so heart failure class, second would be ejection fraction less than 35, those come as no surprise. They're the foundations of our sudden death recognition process. But interestingly here, early repolarization starts with a univariate odds ratio of 4 and actually goes up when it's adjusted. So it does appear to be independent. So as a result, just to summarize those, the guidelines of what happens with early repolarization, we put ICDs in patients whose arrhythmias are attributed to early repolarization, but this is a truly exceptional circumstance. I think more provocative is the question whether when we see it in conjunction with other conditions, this should be drawing our attention to this being a higher risk person who has valvular heart disease, underlying dilated cardiomyopathy, previous myocardial infarction, and so on. So, not being either as eloquent as Elijah or as much of a scientist as Arthur or many of my other friends, I like to try to educate myself a little bit about this, and I have delved into it and tried to summarize it in 2 quick slides for you. So I think this surrounds the question of the terminology of repolarization versus depolarization, and I think for this particular condition, there's probably more weight favoring repolarization than depolarization as opposed to Brugada. And I'll show you a little bit about my musings on that. But imagine a situation where you have, if you like, a certain degree of perfect balance. And this is, Elijah already alluded to this in the Brugada hypothesis. And in that perfect balance, here you have a relatively similar action potential, both in the epi and endocardium, both in the left, right ventricle, inferior wall, apex, etc. But if you have a gradient where you have different action potentials, then you create a voltage gradient, and that voltage gradient can manifest, if it's early, as a notch, or late as ST segment shift. This is part of the hypothesis behind ST elevation in myocardial infarction and pericarditis. So that voltage gradient, and probably the favored channels that are at odds, if you like, are ITO and the sodium channel. So there's two nice review articles on this topic if you want to read around. The senior authors are Dr. Anzelovich and Dr. Natel. And the hypothesis is that, in fact, there's an imbalance. The typical thing in early repolarization is that there's excess ITO, which is why ITO blockers like quinidine are felt to potentially benefit these individuals. And then that gradient, either from different regions or different layers, then predisposes to reentry on the basis of a gradient in action potential. And again, quinidine nitroproterenol helped this. And I welcome the thoughts of the other panelists in terms of their thinking around mechanisms. And so Dr. Anzelovich has coined the term J-wave syndromes with this notion that this family of things shares in common some form of gradient, if you like, particularly of ITO and INA. This, of course, discards the entire depolarization hypothesis, doesn't quite fit with the sodium channel mechanism part of things in Brugada, and also places, I think you would agree that the resting ECG in these four situations as a pure clinician is quite divergent. I would actually argue it's a little bit more like this. If I can get the slide to advance. It's a little bit more like this. So here's Professor Vilda, our distinguished chair, and our keynote speaker. Here's Professor Anzelovich. He's a lumper, wants them all to be J-waves, and he's a splitter in that he thinks the pathophysiology is quite different. But when you think about it, one of the reasons why they're easily lumped together by clinicians like me is because they all respond to the same clinical interventions in some way. But that is, I'm happy to share the slide because I want your AED video. So, okay. So, is that they tend to respond to isoproterenol and quinidine. But if you know anything about quinidine, and I know just a little bit about quinidine, it's a very dirty drug. It does a whole bunch of different things, including ITO blockade, but it's also an IKR blocker, and it has a number of other different functions as well. And so a wedge prep, which does not recapitulate the human condition, combined with a common pharmacologic response, in my mind, places them, if you like, in a similar conversation, but they're not the same thing. They're not variants of the same condition. And so I asked myself, what is in the neighborhood? What's the difference between these pictures? And so if you like, there's three pictures here. So this is the Google image under English row house. So you notice here everything looks the same. So this is this sort of, this is the J-wave syndromes are all the same. And this is, here you notice these are actually all the same kind of thing, but they're decorated differently. So they do look a little different, but you can see the similarity. And here they're all different. And so if I relabel these, we have, this is the Anzelovich strategy, right? They're all the same. They're a row house, okay? And I believe, especially because he's not here, that it's open season on poor Charles, and I'm actually writing a review article with him, so I've got to be a little careful. So here's quinidine street, which is, in fact, the quinidine works, but in fact, these conditions are all a little bit different, but you can see the similarity. And then repol roll, I don't think we would ever lump in CPVT with Brugada, with early repol, with short QT. It just doesn't make sense. So I do want to say one more thing, and this is off topic. This could be my last invite to your fair country, and that is that I was a little disappointed in the nature of the program today, that there wasn't some component of focus on data, informatics, genomics, and so on. When Derek presented earlier on the question of smartphone calling the AED and that kind of thing. That's not so crazy. So 7 years ago, I'm in a boardroom at Medtronic talking about them developing what is now the Reveal Link. And trade-offs were made about what features could potentially go into a device like that. And at the time, Bluetooth was very battery intensive. That device has all of the capability to Bluetooth to your smartphone to call 911. All of the capability. So if it knows if you could say you're reliably in ventricular fibrillation, it could call the ambulance for you. And of course, if it has GPS, it can tell you where to send it. You don't need the daughter, right? Okay? So this is an example of how I think one of the revolutions will happen in technology, and this is a device that's on backorder. They've actually stopped taking pre-orders because they're so backordered. Let's see if I can make this work. Oh, this could be very disappointing if I can't
Smile.
make this work.
No, I'm not taking your picture, I'm taking my picture. Not my face, my body. Not the outside, the inside. This got weird. Let me start over.
See this iPhone case? It's more than just an iPhone case. It's a powerful health monitoring device. These are the sensors where my fingers go. I put them here, and I wait a few seconds.
Now I have a snapshot of my health that looks like this. A readout of my vitals. The kind of stuff you've always needed really expensive machines for. I can now get anytime you want. You can measure your heart rate, your blood pressure, your blood oxygen level, your respiration,
Your heart rate variability, which tells you your stress level. There's even an ECG. That's a fancy way of saying it measures the electrical activity in your heart.
even your temperature. Coming down with a fever, you'll be the first to know. And it does all this with medical grade accuracy. It connects automatically to your phone with Bluetooth LE, sending the data from your sensors to the app, so all your vitals are captured, measured, and logged. And the battery lasts 2 months on a single charge. Keeps on going. Just like you. Use it for your whole family if you want. You can capture data for multiple users and track them all separately in the app.
It measures more than just your heart and your temperature. It even measures your lung functions with the included spirometer attachment, just like what doctors use, but way, way more affordable. The spirometer tells you your lung capacity and airflow. Important stuff.
Already wear a device that tracks your physical activity? It'll sync with the app so you have all your data in one place. The more you know about your body,
They're
the better
selling
you
this
can be
device for
taking care of it.
100 quid.
So smile.
It's an
This
iPhone
is well.
case. And the only downside is when you get a new iPhone, you got to order a new case, right? So because they changed their form factor. The blood pressure on it is accurate to within 4 millimeters mercury. So imagine the next thing, of course, the direct to marketing of the genetics is your patient is going to bring all of their cardiovascular investigations, including their genetic sequence, to you. Okay, that may seem like humor to you, but it's not. It really is. So I think within 5 years, we are completely unprepared for the revolution that's coming, for how informatics are going to change, taking advantage of all the information that we're capable of generating. And on that happy note, I would like to conclude early repolarization is in fact a rare disease. In answer to the question, is it a disease? The second is, repolarization imbalance is a common cofactor in other cardiac conditions, and in fact that's I think how it affects the health of our population. In my humble opinion, the complex interaction of genes, expression mechanics, resultant channels, dynamic factors, make our trying to simplify this into a question of is it a disease or not? Is it early repolarization or syndrome or not? It's almost futile to think that simplistically. And I think the ECG tips that we have are useful tools for the time being until we get a lot smarter. And I thank you very much, and for those of you who are disappointed that we didn't have enough snow at the 2010 Olympics at Whistler, this is what it looks like in summer.